I'm here with Debra Goldstein. Debra, you gave a talk on infectious posterior uveitis in the pediatric population, but let me ask you to sort of map out for us posterior infectious uveitis generally.
Okay, happy to do that. So we're going to back up a little bit even before that. When we talk about uveitis, we need to classify it in a lot of ways. We need to classify it by location. Is it anterior, intermediate, posterior, or panuveitis? We classify it very importantly whether it's infectious or non-infectious. We classify it by onset and timing and course. Is it acute or chronic? We classify it as to whether it's associated with systemic disease or isolated ocular disease. And I always stress infectious posterior uveitis because the biggest mistakes people make in treatment of uveitis is assuming that disease is immune and not infectious, immunosuppressing the patient either locally or systemically for disease that is actually infectious. So very importantly, we consider infectious disease in anybody with uveitis. And although the infections for the majority of cases are in the retina, we can see a lot of anterior segment inflammation. So you can present with pain, redness, photophobia, scleritis or iritis, KP, AC cells, but the primary focus is actually an infectious retinitis. So one huge point in taking care of uveitis patients is that everybody needs a dilated fundus exam. So it's not okay to say that somebody has anterior uveitis and not look in the back of the eye. When we think about infectious uveitis, we can think about the most common infection in the retina in anybody with normal immunity is toxoplasmosis. And that actually accounts for approximately 30% of posterior uveitis in people with a normal immune system. So every ophthalmologist at some point in their career will see a patient with toxoplasmic retinochoroiditis. So we think about toxoplasmosis. The infection is in the retina with inflammation secondarily in the choroid, but also very often granulomatous keratotic precipitates, a high intraocular pressure. So it's a sudden onset of floaters, sometimes pain and redness. Very, very common, as I said, about 30% of posterior uveitis in immunocompetent hosts. Other diseases that we need to think about and not miss are the necrotizing herpetic retinopathies. So acute retinal necrosis, progressive outer retinal necrosis. And this can be with herpes zoster, with herpes simplex, and less commonly with CMV. And again, these patients may present with pain, redness, and photophobia if they have a normal immune system and can mount an exuberant enough immune response. So it's important when you see a patient with redness, pain, etc., that you look in the back of the eye. So those are the ones that are the most common. We also think about, depending on climate, you can get infections with a worm, for example, Duzin. We see more commonly in warm climates than in Chicago, where I'm from, where the ground freezes, so the bugs die. We can think about Candida, and we know the risk factors for Candida and endophthalmitis, either indwelling catheter or systemic infection illness, although just this week we saw a patient with a post-cataract surgery fungal endophthalmitis.
Really?
Yeah, which was sort of surprising, but she has septate hyphae in her eye. So we need to think about infection. Then there are rarer infections. We can think about Whipple's disease in older patients. We can think of Bartonella, which we tend to think about as causing a neuroretinitis, but you can also get multifocal involvement with Bartonella. So there are a lot of organisms that can cause infection. And then the one that we never forget about is syphilis, because syphilis can cause absolutely any uveitis, anterior uveitis, intermediate uveitis, posterior uveitis, panuveitis, scleritis. Syphilis is still around today, and we need to think of that in every patient. And then less common causes, but thing that I still see in my practice is tubercular disease, so Mycobacterium tuberculosis, and then atypical mycobacteria.
So the differential that you've mapped out is nothing short of beautiful, but
it's huge, right?
Yeah, it's huge. So having said that, what is your approach to the patient clinically when the patient walks in?
So that's a great question. So most of these diagnoses are clinical. Toxoplasmosis is a clinical diagnosis. So if it's recurrent disease, you look in and you see an old scar with an adjacent area of white retinitis. Very often there is vitritis in the area, and we can see periphlebitis or periarteritis, either near the lesion or in distal areas. So that's really a clinical diagnosis. And blood testing doesn't help. a quarter of United States adults have positive toxoplasma IgG. If you go to France, 2/3 of adults have positive toxo IgG. And then in Brazil, almost 100% of the population has toxo IgG. So we don't get toxo IgG to make a diagnosis. It's a clinical diagnosis. In acquired toxoplasmosis, we'll see usually a solitary white retinal lesion with, again, surrounding retinal edema and some vasculitis without the presence of an old scar. And here, blood testing is helpful, and we can see the presence of toxo IgM as well as IgG. But again, this is really a clinical diagnosis, and the idea is that you need to think about toxoplasmosis. It is, again, the single most common cause of posterior uveitis if you have normal immunity. So think about it. If you see a paucifocal retinal lesion, this is most likely infectious. Acute retinal necrosis, also mostly a clinical diagnosis. We see peripheral patches of white retinitis with variable amounts of vasculitis and hemorrhage. In acute retinal necrosis in an immunocompetent host, we see quite a bit of vitritis. If the host is immunosuppressed and it's in the porn spectrum, we don't see the vitritis. Again, we need to think of it. If you're not sure, or if you want to know which virus is the cause, which is important to me, we can very easily do an anterior chamber tap and send it for PCR for herpes zoster, herpes simplex, and CMV. Most of these diagnoses you can make if you think about the diagnosis. Syphilis, we diagnose actually serologically. So every single person with uveitis needs specific treponemal tests. So specific tests for syphilis, FTABS or MHATP or TPPA or treponema pallidum IgG and IgM, as well as a non-treponemal test like the RPR and the VDRL. And that we obtain on everybody with ocular inflammation. It doesn't matter if it's an 85-year-old or if it's a priest or rabbi or who it is, they get tested for syphilis. That's a serologic test. We also need to think about tuberculosis in anybody with granulomatous disease, anybody with disease that's not responding appropriately to therapy. I test every patient for tuberculosis. We know that you can get a serpiginous choroidopathy-like picture from tuberculosis, and that we test with either PPD or my preference is the quantiferon gold, which is a blood test.
Right.
So those things we diagnose serologically, but most of the other ones are really clinical diagnoses. You have to think about infection when you see a patient.
Yeah, I mean, clearly you're never going to make a diagnosis that you don't think about. Yeah, Debra, we've covered one little tiny slice of only one sort of uveitis, and it brings me great joy because it means that I get to bring you back at the next meeting to talk about something else with uveitis.
I'd be thrilled. This was wonderful.
Debra,
Thanks so
thank you
much.
very much for spending time with us today.
Thank you so much.